All right, pneumonia, always been the rest of most of the session talking about pneumonia. So the way we classify pneumonias, distribution of the lesions is going to be the key factor. And then secondarily, we're going to classify it by the exudate, just like always. So the distribution of lesions in the lung tells you a lot about the potential route of infection, which is very important because that narrows our list down to certain pathogens. So here's a list of pathogens that enters this way through the air, and then we have another list of pathogens that's coming through the blood. So those distributions are going to be different. So we'll be able to look at the lungs and say, that looks bacterial to me. And they're going to look so smart. So bronchopneumonia is cranioventral distribution, and it's deposition due to, this is where things go due to gravity. So when you breathe things in, obviously not me because I'm even upright, but if you're anatomically this way and you breathe things in, things are going to settle in those cranioventral lobes because that's the first airway that branches off gravity and pulls the particles in. So inhaled, often bacterial agents are going to be the cause of cranioventral bronchopneumonia. So we call it bronchopneumonia because it's aerogenous, it's coming in through the bronchi, and the target is this bronchoalveolar junction. So it's not necessarily targeting the interstitium, the exchange zone. It's more kind of this terminal bronchial region. So predisposing factors are really important for bronchopneumonia. This often requires some kind of impaired pulmonary defense for this to happen because you're constantly breathing in bacteria. Your mouth is full of bacteria, and those bacteria are often the cause of pneumonia because they're opportunistic. So usually you have to have something else has to be wrong to get bacterial bronchitis. Importantly, we talked about the reserve capacity of lungs, about 80%. However, with bronchopneumonia, because of sepsis and all the bacterial toxins being produced, you can get death with as little as 20 to 40% involvement of the lung, and that's just because of all the products. It's not because they can't breathe. So this list of predisposing factors is going to be really important when we get into the specific respiratory disease complexes of the different species. Because these are the ones that producers want to know about. The bacteria are just coming from your mouth. Not really anything we can do about that except prevent these predisposing. Okay, so gross appearance of bronchopneumonia, again, it's going to be cranioventral, super important, and it's going to be consolidated. So the lungs are going to be very thick texture. They're going to be firm. When we feel and see this texture change and it's really severe, we call it epitization, which means it looks like liver, basically. So if I showed you this piece of tissue, you would probably have a hard time telling me that this was lung because it looks like liver. It's just a solid chunk of meat, right? That's because it's so consolidated, so full of inflammatory cells. No air in this lung. You fondle this lung, it's going to feel like liver. So reduced crepitus, lobes are swollen. We've added something. We've added inflammatory exudate. The color is usually going to be abnormal, but remember, you've got to feel it to really know. Only trust it if there's an accompanying texture change. And then look for confirmatory evidence. So is there exudate in the bronchioles, like in this guy? So here we have a pretty nice demarcation line between more normal over here, abnormal over here. And you can actually see there's mucus and exudate in the small airways. So confirmatory evidence. On cross-section, a lot of times you can see inflammation will actually be surrounding the airways. So you'll have a little bronchiole and then you'll have a rim of like thickened white tissue around it, and that's very bronchiolar exudate. And then if the lung is severely infected and you've lost enough air, the lungs will sink. Pneumonia has to be super, super severe for the lungs to sink. I get excited when I see a lung sink, but we see a lot of pneumonia. Doesn't happen often. Okay, so here's some more of what that looks like. Again, cranioventral lung fields, classic. Cranioventral here, cranioventral over here. Here's a cross section where you can see airways. This one's full of mucus. All of them are thickened and have this kind of white rim around them. So that's that peribronchiolar inflammation and exudate, which looks thusly on histo. So here's a little bronchiole that's filled with neutrophils, and all the space around it is just obliterated by inflammation. We can still kind of pick out where the alveolar septa were, but it's getting difficult. And these are little, basically, pus pockets, which are very destructive. Here's kind of a closer view where you can actually still see the alveolar septa, and all the alveolar spaces are filled with neutrophils and lots of fibrin here, all this dark pink gritty stuff. Protein. All right, so aspiration pneumonia is kind of a special subtype of bronchopneumonia. So it's still going to be aerogenous. It's going to be inhaled, aspirated. It's going to be cranioventral, but it's especially going to be this right middle lobe. And that has to do with, again, the anatomy of the bronchial tree and where things go when they're not just breathed in, but inhaled with support. So if I'm this shape and I something, it's going to go to my right middle lobe. So that's the classic location. It can also involve the right cranial lobe. It's going to be unilateral often. So it's going to be a regional lesion, and it's often extremely necrotizing and it smells really bad because these are mouth bacteria. There's a lot of anaerobes. Sometimes it's going to be gastric acid if they vomit and then aspirate. So it's going to be extremely just destructive and nasty. Here's from a cow, and you can see the tissue is like turning green, which some degree of that is going to be postmortem, but this is probably like loaded with bacteria. So it's rotting extra fast, which tells you something about the state it was in before it died. Because look at this area compared to the rest of the body, right? There's some little green patches. This is probably normal postmortem. This regional area, highly suspicious, right? So confirmatory evidence, does this animal have any of these predisposing factors? So has it been vomiting? Does it have a cleft palate? Have we had recent anesthesia? Is there a laryngeal disease? Maybe we've lost part of that barrier function. And then look for aspirated material in the airways. So the farther down you see the aspirated stuff, the more significant it is. As a dead ruminant, their rumen is still working, still going. They're still belching after they die. Very common to see feed material in the trachea of a dead animal, just from the process of dying and rotting and being moved around. So the lower down in the airways, you see it more significant. And then if you culture this, it's not really super rewarding. These are normal flora usually, so it's going to be low pathogenicity, just opportunistic bacteria. The bacteria are really not the problem. It's more whatever the predisposing factor or predisposing disease. Okay, so again, terminal aspiration of feed, really common in large animals. There's food in the trachea. Is this significant? I don't know. Do I see it down in the small airways? So here's a lot of plant stuff sticking out of a tiny little bronchiole. Significant. This animal aspirated. Does it also have cranioventral bronchopneumonia? Yes, definitely aspirated. Cranioventral bronchopneumonia plus food in the bronchioles. We got it. Slam dunk. Food just in the trachea? I don't know. Food in the trachea with no bronchopneumonia? Probably not. Make sense? Okay, second major classification of pneumonia. So bronchopneumonia, aerogenous, usually bacterial. Interstitial pneumonia, targeting the interstitium. So that's this, that's these alveolar membranes. So that's your diffusion zone. Interfering with gas exchange problem. So since this is things that usually come in hematogenously, they're going to come in at the hilus and be caudodorsal to diffuse. So this is the image of that. And I want to point out that this looks very much like the normal lung picture, right? So changes that are diffuse can often be some of the hardest to see because you don't have any adjacent normal tissue for comparison. So again, use your fingers, fondle this lung. Is it firm? Is it soft? What does it feel like? Really tell you what's going on. Because if it's diffuse, chances are you might miss it, especially if you haven't seen a lot of lung. So some confirmatory evidence of this to kind of help you out. Do the lungs fail to collapse when you open the chest cavity? Usually we'll have you, do you guys remember at necropsy lab, GenPath? We check for negative pressure, we poke the diaphragm and it goes, right? So when you do that, when you poke the diaphragm and you go, the lungs are actually deflating because you don't have that negative pressure holding, right? Making a pneumothorax. So if you open the thorax and the lungs don't deflate, you might have some interstitial pneumonia. Rib impressions on the pleural surface. So see all these white stripes here? So not only have the lungs failed to collapse, they were so large in the chest cavity that they're actually pushing against the ribs. And these are basically alternating bands of congestion, right? Because when you're putting pressure on an area, blood will be pushed out of that region. So where the ribs are, there's been pressure. So these lungs are actually too big. They're pushing on the inside of the chest cavity and it's left impressions of the ribs on them. So that's another major indicator that you've got interstitial pneumonia. And then this hepatization, this is not specific for any change. It just means the lungs are too firm and starting to look like liver. You can see this with any type of pneumonia. So not specific for interstitial. Okay, so this guy, normal, soft, pink, fluffy, and especially around these edges here has significantly deflated when we took it out of the chest. This guy, too big. This is filling the open chest cavity, so this is not deflated significantly. There's rib impressions all over the surface. This guy, also way too big, barely looks like lung anymore, right? It looks like a balloon animal of a lung. Look at that crevice right there. It's so like, oh, can you feel this with your eyes? I look at this and it's like one of those hard bouncy balls. That's what this lung feels like to my eyes. Here's a cross section of what that looks like. Again, you'd probably have a hard time telling this from liver, right? Unless I told you that these were, right? This is just so consolidated. This guy is fixed, so that's why the brown texture. And then this one, so this is kind of a special case where have we added something or lost something in these lungs? Outlining lobes for you right here. Is too big or too small? It's small or just right. They're too small. We have an interstitial pneumonia. So what's going on? Reach back to GenPath. Lungs are too small. We've lost something. What have we lost? Air. Anything else? Do they look like atelectasis? So what else have we lost and maybe replaced with? Well, I heard some things. Parenchymal? We lost parenchyma. Yeah, so we've lost air and we've lost lung tissue and we've replaced it with fibrosis. Remember, white, firm, okay, that's fibrosis. So this is like an end stage lung. So diffuse alveolar damage, this is the most common form of interstitial pneumonia. This is actually the type of pneumonia that COVID-19 causes. So it's pretty nonspecific. There are a lot of things that do this, lots of infectious, lots of non-infectious, lots of systemic things can cause diffuse alveolar damage. But what happens is the common pathogenesis is diffuse injury to all your alveolar membranes, your interstitium, right? So you get damage to that this thin little membrane, which is just capillaries and pneumocytes, 4 things, and they get diffusely injured. What happens is these are basically thinly coated capillaries. They start oozing out fibrin everywhere. And you get what are called hyaline membranes, which is what these arrows are pointing to. It's pink globs of fibrin just filling your alveolar spaces. So this is not compatible with breathing. Importantly, this is not helped by being on a ventilator, by being on oxygen therapy, right? Because this is your diffusion. You've injured your diffusion membrane diffusely, right? So oxygen support doesn't necessarily help with patients if it is a diffuse patient. We still give it to them. We try our best. What else can we do? But lots and lots of support here. This is just kind of FYI. You guys don't need to know that. I made this last year when I was actually doing some COVID work in hamsters, so I was nerding out about oxygen. But essentially what happens is this resolves with fibrosis. You can only repair, remember, if you've got basement membranes left. So if you stop this insult or ameliorate it before you lost basement membranes, then you can do some regeneration. Otherwise, you're going down the fibrosis pathway, which is kind of a common. And for I don't know, long COVID to me is kind of confusing, but I think a component of it is probably lost respiratory surface area and fibrosis. Questions on interstitial. Bronchopneumonia coming in through the airways, interstitial coming in through the vessels. Next category, embolic pneumonia. So this, I know you guys remember, check that. So this is that multifocal random pattern that looks like somebody took a shotgun to the tissue and blasted it with little pellets of inflammation. We've got suppurative inflammation in the middle, these little white dots surrounded by a red ring of inflammation, like so. Little white dots in the lung tissue surrounded by a red ring of inflammation. So this is suppurative embolic pneumonia. Can be in any lobe, often it's everywhere. These lesions are flat, sometimes they're raised, and the cause of this is basically a shower of bacteria hitting your bloodstream. So these clusters or chunks of bacteria will lodge in your small capillaries and then incite a local inflammatory response. So some common comorbidities with this are sepsis or especially endocarditis, providing a lot of showering of the lungs constantly. Here's what that looks like in real life. So lots of little pinpoint to coalescing lesions kind of all over, maybe a little bit more cranially, but there's quite a lot caudally too. So not a bronchopneumonia. And then you can see little white spots with red around them. Similar here. I think this might be a pig. I'm not sure. But all these little pinpoint red foci. Some of this could also be hemorrhage too. See how some of these red lesions are kind of spreading a little bit. And that's because you do have a vasculitis with these. The bacteria are lodging in your capillaries and the cause of vasculitis around that capillary. Here's a cross section, so you can see multifocal kind of coalescing these dark spots. So these are actually necrotic in the center. And then you have that red rim of active inflammation right around the edge. Airways are clear. This is not a bronchopneumonia. Granulomatous. So similar pattern to embolic, multifocal random, can be anywhere. However, this is a chronic change. So embolic pneumonia is acute. It's suppurative inflammation. It's fibrin, hemorrhage, acute, juicy things. Granulomatous, these are going to be firm, associated with a lot of fibrosis around the edge. So this is a chronic lesion. It's proliferative. Causes are the same as basically anywhere else you see granulomatous inflammation. So fungi, bacteria, tuberculosis is kind of the prototype for granulomatous pneumonia. So here's what that looks like. Again, similar pattern to embolic pneumonia, but if you palpate this, this will be firm. If you cut into these on cross section, you'll often see fibrosis intervening between the tissue. So these are big case-eating granulomas. Here, this kind of white to tan tissue between the granulomas, that's all fibrosis trying to encapsulate all this thing off. Here's what tuberculosis looks like in a bird. So these are bird lungs because see these little stripes. So this is that area here up by the ribs. It's tucked back in there. It's bird lung, and here's the syrinx by the patient.